Good morning. Before we start, let me first introduce our group. I'm Lowe, and my group mates are Yongwon, Ji, and Sharon from Batch 9. Today, our seminar topic is non-odontogenic cysts of orofacial region. These are our learning objectives. To classify non-odontogenic cysts, describe the pathogenesis and clinical features and radiographic features of non-odontogenic cysts, and also differentiate non-odontogenic cysts histologically. Now let us see the definition of a cyst. Cyst is a pathologic cavity, often fluid-filled, that is lined by epithelium. According to Sheffers, cysts in the orofacial region not essentially derived or related to the odontogenic apparatus are called non-odontogenic cysts. Non-odontogenic cysts are classified into developmental and also inflammatory. Under developmental, they are intraosseous and extraosseous. The example for intraosseous cysts are nasopalatal duct cysts and median palatal cysts. For extraosseous, there is branchial cleft cyst, palatal cyst of newborn, nasolabial cyst, pteroglossal duct cyst, oral lymphoepithelial cyst, epidermoid cyst, and also dermoid cyst. Under inflammatory, there is traumatic and also infectious. Under traumatic, there is salivary cyst, enteral pseudocyst, traumatic bone cyst, aneurysmal cyst. Under infectious, there is parasitic. So now let us discuss on nasopalatal cyst, which also known as incisive canal cyst. It is the most common non-odontogenic cyst of the oral cavity. It occurring in about 1% of the population. Nasopalatal duct cysts are believed to arise from remnants of the nasopalatal duct, an embryologic structure connecting the oral and nasal cavities in the area of the incisive canal. There are few possible etiologic factors. First, trauma or infection of the duct, or the mucus retention of adjacent minor salivary glands. Although pathogenesis of this lesion is still uncertain, the lesion most likely represents a spontaneous cystic degeneration of remnants of the nasopalatal duct. So it can develop at almost any age, but is most commonly in the 4th to 6th decades of life. It is mere predilection. It appears as a swelling of the anterior palate, drainage, and also pain. However, many lesions are asymptomatic and discovered on routine radiographs. Rarely, a large cyst may produce a true and true fluctuant expansion involving the anterior palate and labial alveolar mucosa. Now let's move on to the radiographic features. It appears as a well-circumscribed radiolucency in or near the midline of the anterior maxilla, between and apical to the central incisor teeth. The lesion most often is round or oval with a sclerotic border. Some may have inverted pear shape. It is due to a resistance of adjacent tooth roots. Others may show a classic heart shape. It is due to the superimposition of nasal spine or the notch by the nasal septum. Radiographic diameter of the lesion range from 6 mm to 6 m, but it's mostly 1 to 2.5 cm. In rare instances, a nasopalatal duct cyst may develop in the soft tissues of incisive papilla area without any bony involvement. This is known as the cyst of the incisive papilla. In the radiographic, you can see the lesion is around behind the anterior and it appears as a heart shape. Now let us discuss the histopathological features. Epithelial lining of nasopalatal duct cyst is highly variable. It may compose of the following: stratified squamous epithelium. This is the most common epithelium that occurs in the lesion. It presents in at least 3/4 of all cysts. Next is pseudostratified columnar epithelium. It forms from 1/3 to 3/4 of the cysts. Simple columnar epithelium and simple cuboidal epithelium are the least that can see in the histopathology of nasopalatal duct cysts. Frequently, more than one epithelial type is found in the same cyst. The type of epithelium depends on the location of the cyst. If it is near the nasal cavity, it is called respiratory epithelium. If it is near the oral cavity, it is squamous epithelium. Cilia and goblet cells may be found in association with columnar findings. The contents of the cyst wall can be a helpful diagnostic aid. Moderate-sized nerves and small muscular arteries and veins usually are found in the wall of the cyst. Occasionally, small islands of hyaline cartilage can be seen. Small mucous glands may also be seen. An inflammatory response is noted in the cyst wall, usually is chronic and composed of lymphocytes, plasma cells, and also histiocytes. These are the flattened cuboidal epithelial cells, as you can see, and those red are the inflammatory cells. Next, on the right side, you can see the salivary glands, and also on the left side is the nerve bundles. The next non-odontogenic cyst I'll be discussing is median palatal cyst. It is a rare fissural cyst. It develops from epithelium attract along the embryonic line of fusions of the lateral palatal shelves of the maxilla. In clinical features, it shows firm or fluctuant swelling of the midline of the hard palate posterior to the palatine papilla. It is most common in young adults. It is often asymptomatic, but some may complain of pain or expansion. The average size of the cyst is 2 × 2 cm. In radiographic features, it shows well-circumscribed radiolucency in the middle of the hard palate, occasionally associated with divergence of the central incisors. It must be stressed that a true median palatal cyst should exhibit clinical enlargement of the palate. A large midline radiolucency without clinical evidence of expansion is probably a nasopalatine duct cyst. This is the radiographic for the median palatal cyst. As you can see, the lesion is at the hard palate. Is radiolucency. To differentiate median palatal cyst from other cystic lesions of maxilla, Ginger and associates suggested the following diagnostic criteria. Grossly appeared symmetrical along the midline of the hard palate. Is located posterior to the palatine papilla. It appears as a ovoid or circular radiographically. Is not intimately associated with a non-vital tooth. It does not communicate with the incisive canal. It shows no microscopic evidence of large neuromuscular bundles, hyaline cartilage, or minor salivary glands in the cyst wall. The histopathologic features of median palatal cyst is lie by stratified squamous epithelium. Areas of ciliated pseudostratified columnar epithelium may be seen. Chronic inflammation may be present in the cyst wall. This is the histopathologic slide for median palatal cyst. Next, we will be discussing about extra-osseous developmental non-odontogenic cysts. First, we will discuss branchial cleft cyst. Branchial cleft cyst is also known as cervical lymphoepithelial cyst. It is a developmental cyst derived from remnant of branchial arches. During 4th week of gestation, the paired branchial arches is covered by ectoderm on the external surface and endoderm in the internal surface, which eventually develop branchial clefts and pouches. The clefts and pouches are gradually eliminated by ingrowth of mesenchyme. However, incomplete elimination of pharyngeal clefts and pouches gives rise to the branchial cleft cyst. Majority of the cyst is derived from second branchial arch. In the clinical features, it is normally found in the anterior upper lateral neck or deep to the sternocleidoid mastoid muscles. It is frequent in children or young adults, aged between 10 to 40 years old. It appears as a soft or fluctuant mass, and the diameter is ranged from 1 to 10 cm. Associated tenderness or pain sometimes may occur with secondary infection. Occasionally, the lesion becomes more evident after an upper respiratory tract infection or trauma. Now, Let us see the histopathological features of branchial cleft cyst. It is lined by keratinized or non-keratinized stratified squamous epithelium. Some cysts will exhibit respiratory epithelium. The wall of the cyst typically contain lymphoid tissue and often demonstrate germinal center formation. This is the pathology slides for branchial cleft cyst. Medium power view showing a cyst lined by stratified squamous epithelium. Note that the lymphoid tissue is in the cyst wall. And from this histopath slides, we can see the germinal centers is located at the right middle area where it's circled.
I'll be talking about the palatal cyst of newborn. Palatal cyst of newborn is also known as Epstein's pearls or Bourne's nodules. It's a common finding on the palate of newborn infants. It's arrived from when the palatal shelves meet and fills in the midline during embryonic life to form the secondary palate. Small islands of epithelium may become entrapped below the surface along the median palatal raphe, and finally it forms the cyst. The second theory is the epithelial remnants derived from development of minor salivary gland of palate. The clinical features are: it's a common lesion in newborn. The cysts are small, which is 1 to 3 mm in diameter. The lesion usually appears as white or yellow-white papules. It most often appears along the midline near the junction of hard and soft palate. It may also occur in a more anterior location, which is along the raphe or on the posterior palate lateral to the midline. The lesion usually appears as clusters of 2 to 6 cysts. Sometimes we can see the lesion occur singly. So this is the palatal cyst of newborn. In histopath features, we can see keratin-filled cysts that are lined by stratified squamous epithelium. Sometimes these cysts demonstrate communication with the mucosal surface. Next, I'll be talking about nasolabial cyst. Nasolabial cyst is a rare developmental cyst that occurs in the upper lip lateral to the midline. The pathogenesis of nasolabial cyst is uncertain, but there's two major theories. The first theory is nasolabial cyst is considered to be a fissural cyst arising from the epithelial remnants entrapped along the line of fusion of maxillary, medial nasal, and lateral nasal processes. The second theory is the cyst is developed from misplaced epithelium of nasolacrimal duct because of their similar location and histological appearance. So what are the clinical features of nasolabial cyst? Nasolabial cysts appear as a swelling on the upper lip lateral to the midline, resulting in elevation of ala of nose. The enlargement often elevates the mucosa of the nasal vestibule and obliterates the maxillary mucolabial fold. The lesion is usually asymptomatic, but if there's pain, it's usually associated with secondary infection. The cyst may rupture spontaneously and drain into the oral cavity or the nose. It's a lesion that is commonly seen in adults who are in their fourth or fifth decades of life, and it shows slight female predilection. The lesion is usually unilateral, and sometimes we can see it bilaterally. In most cases, there's no radiographic changes are seen. Occasionally, pressure resorption of underlying bone may occur. So this is the nasolabial cyst. In histopathological features, the cyst is lined by pseudostratified columnar or stratified squamous epithelium. If it's lined by pseudostratified columnar epithelium, it often demonstrates Goldberg cell and cilia. There's also areas of cuboidal epithelium and squamous metaplasia. The cyst wall is composed of fibrous connective tissue with adjacent skeletal muscle. If there's secondary infection, inflammation may be seen. So we can see pseudostratified cuboidal epithelium here. There's fibrous connective tissue in the cyst wall, squamous metaplasia here, and And here's demonstration of goblet cell. Next, I'll be talking about thyroglossal duct cyst. Thyroglossal duct cyst begins its development during the 3rd to 4th week of embryonic life as a proliferation of endodermal cells from the ventral floor of pharynx, which is between tuberculum impar and copula of the developing tongue, which later becomes foramen cecum. It usually develops in the midline and may occur anywhere from foramen cecum area of tongue to suprasternal notch. It is commonly developed adjacent to the hyoid bone. Suprahyoid cysts may be submental in location. The cysts that are developed in area of thyroid cartilage often are deflected lateral to the midline because of the sharp anterior margin of the thyroid cartilage. Intralingual cysts are very rare. This lesion can develop at any age, but commonly can be diagnosed in the first 2 decades of life, and it shows no sex predilection. The lesion is usually present as a painless, fluctuant, movable swelling unless it is complicated by secondary infection. The lesion developed at the base of the tongue may cause laryngeal obstruction. In most lesions, they are smaller than 3 cm in diameter, but they can reach up to 10 cm in size. If the cyst maintain an attachment to the hyoid bone or tongue, it will move vertically during swallowing or protrusion of tongue. Sinus tract to skin or mucosa can be developed usually because of rupture of an infected cyst or as a sequela of surgery. So these are photos of thyroglossal duct cyst. In histopathological features, the cyst is lined by columnar or stratified squamous epithelium. Sometimes we can see mixture of epithelial types present, or we can observe an intact epithelial lining that cannot be found due to secondary infection. Thyroid tissue can be seen in the cyst wall, but is a non-constant feature. So we can see this is a cystic space. The cyst is lined by stratified squamous epithelium here, and thyroid tissue can be seen here.
Moving on to the oral lymphoepithelial cyst, it is an uncommon lesions of the mouth that develop within the lymphoid tissue. Microscopically, it looks similar to the branchial cleft cyst, but much more smaller in size. The oral lymphoid tissue has a close relationship with the overlying mucosa epithelium. The epithelium usually will demonstrate invaginations into the tonsillar tissue, which results in the formations of blind pouches or tonsillar crypts that may fill up with keratin debris. The tonsillar crypts later may become obstructed or pinched off from the surface, which produce a keratin-filled cyst within the lymphoid tissue just below the mucosa surface. Oral lymphoepithelial cysts may also possibly develop from salivary or surface mucosa epithelium that becomes enclaved in lymphoid tissue during embryogenesis. In the clinical features, the size, it is usually less than 1 cm in diameter, rarely greater than 1.5 cm. It can be firm or soft to palpation, and the overlying mucosa is smooth and non-ulcerated. In the clinical presentation, it may appear as white or yellow in color and often contains creamy or cheesy keratinaceous material in the lumen. It is asymptomatic, and occasionally patients may complain of swelling or drainage, and pain is very rare, but it may occur secondary to trauma. This cyst may occur at any age, but most commonly is seen in the young adults, and the sites for this cyst formations is at the floor of the tongue, the ventral tongue, the posterior lateral border of the tongue, the palatine tonsil, and the soft palate. All these above locations that I mentioned just now are the representative sites of the normal or accessory oral lymphoid tissue. At the top left picture, there is a small yellow-white nodule which is seen at the tonsillar fossa, whereas at the right bottom picture, there is a small white papule on the posterior border of the tongue. Moving on to the histopathological features, there is a cystic cavity which is lined by stratified squamous epithelium without the rete ridge, and the epithelium is typically parakeratinized with desquamated epithelium cell filling with the cyst lumen. In rare instances, the epitheliums will contain mucosa cell. Occasionally, the cyst may communicate with the overlying mucosa surface. And the hallmark features for this oral lymphoepithelial cyst is that the presence of lymphoid tissues in the cyst wall, which encircle the cyst, but sometimes it only involves a portion of the cyst wall. The germinal centers are usually, but not always present. As you can see at the top right histopathological pictures, you can see there is presence of epithelial lining without the presence of rete ridge, and there is presence of lymphoid tissue at the cystic wall. At the bottom left pictures, there are presence of keratinaceous material in the cystic lumen and lymphoid tissue at the cystic wall. Moving on to the epidermoid cyst, or it can also known as infundibular cyst, it is the most common type of follicular cyst of the skin. It is a type of keratin-filled lesions that arises from one or more portions of the hair follicle, and in this case, it is derived from the follicular infundibulum. It can arise after a localized inflammation of the hair follicle and probably represent a non-neoplastic proliferation of the infundibular epithelium resulting from the healing process. The clinical features. So the most common site for the formations of this cyst is at the acne-prone area of the head, neck, and back. However, young adults are more likely to have the cyst on the face, whereas the older adults are more likely to have the cyst on the back. The age, it is unusual before puberty unless associated with Gardner syndrome, and the male are more prevalent than female in this case. And in the clinical presentations, it usually appears as a nodular flatulent subcutaneous lesions, which may or may not associated with inflammations. If not inflamed lesions present in an area of the thin skin, such as earlobe, it may be white or yellow. And oral lesions are very rare, and the lesions mainly affects the skin. As you can see at the left clinical picture, it is a yellow nodule at the lateral aspect of the eye, whereas at the right clinical picture, it is a yellow color cyst in the floor of the mouth. In the histopathological features, a cavity lined by stratified squamous epithelium resembling the epidermis can be appreciated. A well-developed granular cell layer is seen, and the lumen is filled with degenerating autokeratin. If the epithelial lining gets disrupted, a prominent granulomatous inflammatory reactions will take place, which causes the presence of the multinucleated giant cells in the cyst wall, because the exposed keratin is recognized as a foreign material. As you can see in this histopathological picture, abundant keratin fills up the cystic cavity, and the epithelium is lined by stratified squamous epithelium which resemble the epidermis. Next is dermoid cyst, which is also known as odontogenic cyst. It is an uncommon developmental cystic malformation lined by the epidermis-like epithelium and contains dermal and maxillary structures in the cyst wall. Generally, it is classified as a benign cystic form of teratoma, and dermoid cyst is simpler in structures than the complex teratoma or teratoid cyst, as it do not contain tissue from the all three germ layers. As you can see at the right side, it is a clinical picture showing that there is a fluctuant swelling in the floor of the mouth. Clinical features. The most commonly occurred site is at the midline of the floor of the mouth, which occasionally will displace laterally or develop in other locations. For example, if the cyst develop above the glenoid muscle, it will cause a sublingual swelling which displaces the tongue towards the roof of the mouth, in which the patients will have difficulty in eating, speaking, or even breathing. If the cyst develop below the glenoid muscle, it will cause submental swelling with a double chin appearance. Later in the next slides, I will show you guys the pictures of these two scenarios so you guys will have a better understanding on it. So moving on to the size, it is vary in size from a few millimeter to 12 cm in diameter. Age, it is most common in children and young adults, and it appears as a slow growing and painless cyst. It presents as a doughy or rubbery mass that frequently retains pitting after applications of pressure. So this is the pictures that shows that the cyst grows above the glenohyoid and below the glenohyoid. Moving on to the histopathological features, it is a cyst which lined by autokeratinized stratified squamous epithelium with a prominent granular cell layer, and there is abundance of keratin is found within the cyst lumen. The cyst wall composed of fibrous connective tissues that contains one or more skin appendages such as sebaceous gland, hair follicle, or sweat glands. As you can see in this histopathological picture, the cyst is lined by autokeratinized squamous epithelial lining, and the site which labeled as F is the hair follicle, and the site which labeled as S is the sebaceous gland. So that's the end for developmental non-odontogenic cysts. Now moving on to the inflammatory non-odontogenic cysts with traumatic origin. So the examples are salivary cysts, antral pseudocysts, traumatic bone cyst (TBC), and aneurysmal bone cyst (ABC). So now I've been explaining about the salivary cysts, which includes mucocele, ranula, and salivary duct cysts. So the first one will be mucocele. Mucocele is also known as mucus extravasations phenomena or mucus escape reaction. It is a common lesion that results from the ruptures of the salivary gland duct and causes the spillage of the mucin into the surrounding soft tissue, which results from a local trauma. It is not a true cyst because it does not have any epithelial lining. As you can see in these clinical pictures, there is a blue pigmented nodule on the lower lip. Clinically, it appears as a dome-shaped swelling which ranges from 1 to 2 mm to several centimeters. It usually occurs in children and young adults as the younger patients are most likely to experience trauma. The splitter mucin below the mucosa surface often imparts a bluish translucent hue to the swelling, although the normal mucosal may be in normal color. It appears as an asymptomatic flatulent swelling, and sometimes it may be firm to palpation. The duration will last from few days to several years, and it usually occurs at the lower lip found lateral to the midline and followed by the floor of the mouth, the anterior ventral tongue, buccal mucosa, palate, and retromolar pad. The variance for mucocele is known as the superficial mucocele, in which this mucocele develops on the soft palate or retromolar pads along the posterior buccal mucosa, and it bursts leaving a shallow painful ulcer and heals, which will heal within few days. So the second one will be ranula. Ranula is a swelling which is similar to mucocele that occur in the floor of the mouth, but it is usually arising from the sublingual gland. Rana in Latin means frog, as the swelling resembling a frog's translucent underbelly. The etiopathogenesis for ranula is the same as in mucocele, in which it is caused by trauma, which leads to the spillage of mucin into the surrounding soft tissue. As you can see in this clinical picture, there is a blue pigmented swelling which is found at the left floor of the mouth. Moving on to the clinical features, ranula usually appears as a blue dome-shaped flatulent swelling in the floor of the mouth, and the deeper lesions may be normal in color. Like mucocele, it is asymptomatic and usually occurs in children and young adults. However, it is larger than mucocele. So the most common site for ranula to occur is at the lateral to the midline of the floor of the mouth, and the variant for ranula is known as the plunging ranula or cervical ranula, in which the swelling occurs within the neck as the spill mucin dissect through the mylohyoid muscle. And you can see in this clinical picture, it is actually the plunging ranula in which the mucin spill and dissect through the mylohyoid muscle. The histopathological features for both the mucocele and ranula are actually the same, in which there are spilled mucin surrounded by the granulations tissue and presence of numerous foamy histiocytes. An adjacent minor salivary gland will show chronic inflammatory cells infiltrations and dilated ducts. In the right side, you can see that there is a histopathological pictures which shows that mucins fill cyst-like cavity which is beneath the mucosa surface, and there are minor salivary glands present below and lateral to the mucin pool. In these histopathological pictures, you can see there are numerous of foamy histiocytes. So now moving on to the last salivary cyst that we're going to discuss today, which is the salivary duct cyst or the mucus retention cyst or the mucus duct cyst or cellocyst. It is an epithelium lined cavity and it is a true developmental cyst that is lined by the epithelium that is separate from the adjacent normal salivary duct. The cyst-like dilatations of the salivary duct also may develop secondary to the ductal obstructions. So as you can see in these clinical pictures below here, it is a nodular swelling which overlying the Wharton's duct. Moving on to the clinical features, it is usually seen in adult and it can arise from the major or minor salivary gland. In the case of major salivary gland, it is usually occur within the parotid gland, whereas in the minor salivary gland, it is usually occur in the gland which is located in the floor of the mouth, the buccal mucosa, or the lips. It is appear as a slow-growing, asymptomatic, soft and flatulent swelling that may appear bluish depending on the depth. In the histopathological features, a thin or mucoid secretions in the lumens can be seen surrounded by a cuboidal, columnar, or atrophic squamous epithelium. The ductal ectasia secondary to the salivary obstructions is characterized by oncocytic metaplasia of the epithelial lining. The epithelia often demonstrate papillary flows into the cystic lumen, somewhat reminiscent of a small Wharton's tumor but without prominent lymphoid stroma. The both clinical pictures show cyst space surrounded by the epithelium, and at the right bottom clinical picture, it shows that it is a cuboidal epithelium and the excretory salivary duct is lined by the columnar epithelium.
Now I'll continue with another inflammatory non-odontogenic cyst, which is antral pseudocysts. Antral pseudocysts are often misunderstood as sinus mucocele or sinus retention cyst. It appears as dome-shaped, faintly opaque lesion arising from the floor of maxillary sinus. It develops due to accumulations of inflammatory exudate beneath the maxillary sinus mucosa, causing a sessile elevation. The inflammatory exudate which is formed is in the form of serum but not mucus. The edematous fluid is in the stroma underneath the epithelium, not surrounded by the epithelium. The cause of inflammatory infiltrate has not been determined definitively, but many cases show possible source from an adjacent odontogenic infection. Sinus infection, allergies, upper respiratory tract infection, irritations from dry, forced air heating can result in inflammatory infiltrate formation. From the diagram above, you can see that it shows the difference between an antral pseudocyst and a true mucocele. The fluid within the antral pseudocyst is not surrounded completely within the epithelium, unlike the true mucocele. The clinical features of antral pseudocyst is that it is asymptomatic usually. Occasionally, patient will complain of headache, facial sinus pain, nasal obstruction, postnasal drips, and nasal discharge. However, these symptoms are not relieved by removals of the pseudocyst. Radiographic features shows uniform, spherical, or dome-shaped radioopaque lesion arising from the floor of maxillary sinus. The radioopaque floor of the sinus extends over the superior aspect of the lesion. Radiographic differential diagnosis mainly are maxillary cyst and neoplasm. From the radiograph, you can clearly see dome-shaped radioopaque lesion, which is pointed in white arrow in the first and second pictures on the left side. And the pictures on the right side shows the uniform dome-shaped radioopaque lesion arising from the floor of the maxillary sinus. Histopathological features of antral pseudocyst: it is lined by sinus epithelium, which is pseudostratified ciliated epithelium. It demonstrates subepithelial inflammatory exudate that consists of serum occasionally intermixed with inflammatory cells. It also shows cholesterol clefts and scattered small dystrophic calcification. So from the histopath pictures above, it shows pseudostratified ciliated epithelium as the epithelial lining, and subepithelial layer shows inflammatory cells, and on the right corner you can see some cholesterol. Next is surgical ciliated cyst. Surgical ciliated cyst is also known as traumatic ciliated cyst or post-operative maxillary cyst. It occurs after trauma or surgery to the sinus. Portions of the sinus lining become separated from the main body and forms an epithelial lined cavity into which the mucus is secreted. It originates after Calvelluc operation or from difficult extractions of maxillary tooth in which the floor of the sinus is damaged. Accidental transplantations of the sinus or nasal epithelium during genioplasty or chin augmentation may lead to ectopic ciliated cyst formation. Clinical features: it usually appears in middle-aged or older individuals. Patient will complain of non-specific poorly localized pain, tenderness, or discomfort in the maxilla. It may appear as an extraoral and intraoral swelling. So ask the patient for any previous history of surgical procedure done involving the maxilla or maxillary sinus for the past 10 to 20 years in order to diagnose the lesion. Radiographic features: it appears as a spherical lesion that are separated from the sinus. Enlargements of the post-operative cyst can cause perforations of the sinus wall. In the radiograph, you can see that the one that are circled in red shows the radiolucent spherical lesion in the maxillary sinus, whereas on the right it shows an ectopic ciliated cyst which appear in the mandible when the respiratory epithelium was transplanted from the Lefort 1 osteotomy in the maxilla to the mandible during genioplasty procedure. Proceed to histopathological features. It appears as a true cyst. So it is lined by ciliated pseudostratified columnar epithelium or squamous epithelium with mucous cells or metaplastic squamous epithelium. So from these histopath features, you can see pseudostratified ciliated columnar cells as the epithelial lining. Next is simple bone cyst. Simple bone cyst is also known as traumatic bone cyst, hemorrhagic bone cyst, idiopathic bone cyst, idiopathic bone cavity, unicameral bone cyst. There are many theories which explain the pathogenesis of a simple bone cyst. One of the theories says that trauma which is insufficient to cause bone fractures results in an intraosseous hematoma. The hematoma that does not undergo organization and repair will liquefy and form a pseudocyst defect. Other theories also include venous obstruction, local disturbance in bone growth, altered calcium metabolism, ischemic marrow necrosis, aberrant synovial development, and degenerations of bone tumor or cyst. Clinical features of a simple bone cyst: it appears as a solitary bone cyst arising in the jaw with mandibular predominance. It usually appears at the premolar, molar, and symphysis region. Usually affect young patient, second decade predominance. There is no significant gender bias. Male predilections for extranetic lesion. Lack clinical signs and symptoms. It is usually 20% shows painless jaw swelling, and pain and paresthesias are infrequently happening. Radiographic features of this lesion: it is well defined. It can be well defined or ill defined. It can be unilocular or multinocular. It usually are radiolucent lesion. However, typically, as a simple bone cyst appears as well defined unilocular radiolucency. It is usually 1 to 10 cm in diameter, dome-like projections that scallop upwards between the roots of adjacent teeth. A cone-shaped outline pointed in one or both ends anterior-posteriorly may be noted in a larger lesion. It appears as an oval, irregular, or rounded borders, and however the adjacent teeth are usually vital. In the first radiograph on the left side, it shows a well-defined multinucleated lesion, and if you look closely, you can see the projection which scallop upwards between the roots. Histopathological features of a simple bone cyst. It is a pseudocyst, which means it does not have an epithelial lining. Instead, it is lined by a thin band of vascular fibrous connective tissue or thickened myxofibromatous proliferation with reactive bone. Fibrin, scattered erythrocyte giant cell, lace-like dystrophic calcifications are found. Horse-shaped lacunae, which is a resorptive areas found in the bony surface next to the cavity. So from the histopath pictures given, the pictures on the left side show scattered erythrocytes, and the pictures on the right side shows a lace-like calcification with some amount of erythrocytes scattered. Diagnosis is primarily based on clinical, radiographic, and intraoperative finding. 2/3 of the cases, the cavity contains small amount of serosanguous fluid, mandibular neurovascular bundle lying free in the cavity. In minority, 1/3 of the cases shows empty cavity with smooth, shiny bone wall. Next is aneurysm bone cyst. It is a reactive lesion, can be primary or secondary. It occurs due to traumatic event, vascular malformation, or neoplasm, which disrupt the normal osseous hemodynamic, resulting in enlarging areas of hemorrhage and osteolysis. Clinical features of aneurysm bone cyst. It primarily occurs in a long bone or vertebra of patient younger than 30 years. Only 2% of cases involving the jaw. It usually affects young patients, peak in second decade. There is no significant sex predilection. However, in some cases, it might have slight female predilection. It occurs more frequently in the mandible compared to the maxilla, most often seen in the posterior region compared to the anterior region, and it is a rapidly enlarging swelling. Pain, paresthesias, and crepitus may be noted. Malocclusion, mobility, migration, or resorptions of the affected teeth may be seen. Maxillary lesion will bulge into adjacent sinus, causing nasal bleeding, nasal obstruction, proptosis, and diplopia. Radiographic features shows it can be well defined or poorly defined. It can be unilocular or multilocular. It is a radiolucent lesion. There will be a marked cortical expansion and thinning of the cortical bone. There will also be a ballooning or blowout distensions of the affected bone. Uncommonly, there will be a small radioopaque foci noted within the radiolucency. Intraoperatively, when the periosteum and bone shell are removed, the lesion exhibits dark venous-like bleeding with blood-soaked sponge appearance. So from the radiograph above, it shows blowout distensions of the affected bone. Both the radiograph shows multinucleated radiolucency in the posterior mandibular region. Histopathological features of aneurysmal bone cyst is that there will be a blood-filled space of varying size, and there is no epithelial or endothelial lining, just like the traumatic bone cyst. Aneurysm bone cyst does not have epithelial lining as well. Cellular fibroblastic tissue containing multinucleated giant cells, osteoid, and woven bone. The multinucleated giant cells exhibit osteoclastic phenotype, which is evidenced by immunohistochemical and in situ hybridization studies. Osteoid may appear as linear, nodular, or lace-like. So as you can see from these histopath features, there is a blood-filled space with some multinucleated giant cells present at the right corner. And the second picture shows woven bone and also blood-filled spaces. So here's the Socrative. So I've launched the Socrative so you guys can try, and this is the code. So there are total 20 questions, so you guys can try it out. And this is the reference. That's all from us. Thank you.